the main organizers of this meet, Professor Sushil, Dr. Sohail, Dr. Rajmohan, and my colleagues in psychiatry and friends. Let me at the very outset thank Dr. Sushil and Sohail for having invited me for this function as the guest of honor. In fact, I really enjoyed reading the title of this today's academic program, Dilemma. What is meant by dilemma? Dilemma is a very unusual circumstance when a professional is demanded or needed to choose between one or more, two or more alternatives, which of course are all undesirable. That's the meaning of dilemma. And even today, in spite of traversing for such a long decades in psychiatry, we know the dilemma persists. For example, take for instance bipolar disorder. Except the name has changed. In our times in the 70s, we used to call it manic depressive psychosis. Before that, it used to be manic depressive insanity. What things have changed? I'm keen to listen to Professor Sabin Kumar in bipolar disorder, except that the name has changed. And the DSM, which of course my esteemed colleague Dr. Mohanchandran referred, has an attitude or system to keep on changing the names. What is there in the name? Whether we call it manic depressive psychosis or bipolar disorder, it is one and the same. The only difference is I still remember in the 70s when lithium came in our circle, our excitement. I don't know how many of my professional present colleagues share this excitement, but I still have that excitement because there is yet no substitute for lithium. And I still remember my great teacher referring as is one of the three wonders in medicine. The first wonder he used to say is antibiosis. The second is rehydration therapy, and the third is lithium. Lithium was a great answer, not even low promising, because lithium just revolutionized the whole concept of psychiatry. Because initially everything used to be psychosis, neurosis, whatever name you call. But then when lithium came into the market for our use, we were forced. If there's a drug which tells you must revise your diagnostic pattern. Because what now used to call as affective disorder, there used to be two classifications, schizophrenia and affective disorder. And you must make a positive effort to make a diagnosis of affective disorder so that you can use lithium. Of course, now people say rapid cycling, they challenge lithium, lithium gets revisited, lithium gets no visit, whatever. Even today to my colleagues in psychiatry, I'm a fan of lithium even today. I still continue to use lithium. Perhaps the only effort you have to do is you have to persuade your patient and the relatives to make periodic blood checking. And they do agree. Because in psychiatry, the problem is we do not have much blood investigative procedures. People, of course, now since CT scan, MRI have come, we have a couple of that. But old-timers like me are not so fanciful unless it is indicated. I don't go for CT scan. I remember years ago when the first CT scan, Fatima Hospital introduced, people used to ask, sir, what is CT scan when? So I used to tell Abdullah is much richer not to get replenished by your money. You better keep it in your purse. And they used to understand that. Maybe a bit frustration on their part because they expect that. But then After lithium, we have one periodic serum lithium estimation. I still remember, I enjoy, but now I'm not very sure. We have to be really careful about serum lithium estimation. I remember the great teacher who used to draw blood himself from day one. Jubilee Madam's husband, our wife was professor. Great teacher. Sometimes when we don't instruct the patient of 12 hours, he specifically asks, when you ask us who is the doctor, did he advise you? I mean, such a meticulous person. I still remember the first time I had to go and meet him. Such a respectful person. He was like, after that I'm not very sure with the serum lithium level to look at. But for official reasons or from a litigant's point of view, you have to get it periodically estimated. So having said that, psychiatry is one branch, as Mohanchandran has rightly mentioned, to keep on changing. A lot of drugs, when I entered, there was only a dozen drugs, not even a dozen drugs, we have to keep it. Must be 10 less than 10. Now there are innumerable drugs which we can't keep track. It comes and goes. Something comes and disappears. But there are certain things like chlorpromazine, lithium, which still stays. We start, and that way this continuing medical education program is essential. Not just that medical council insists that you have to attend, you have to occur. Apart from that, it is very important, and I must congratulate the organizers. I hear Sushil mentioning Raj Mohan's name but if I were asked, I would have suggested one topic, that is ethics in psychiatry. That's extremely important. See, for example, there was a time when we did not realize that our patients did not have capacity. Patients did not have autonomy. People never bothered whether they had capacity or autonomy. And now it is extremely important. People used to think that our patients, psychiatric patients, psychotics, they don't really understand. But remember, youngsters, they are very perceptive. Every movement, every word, from my own personal experience. I still recall one instance, and I would stop at that. I would not make it more lengthy. One day, years ago, it was in the early 80s. I remember, those are the days when we were waiting for patients. I remember my teacher saying that initially we wait for patients, then patients wait for you, and the patients run after. This is our own medicine professor. He is no more, Professor Hari used to say. So I remember recently when I met Professor B.M. Hegde, my great teacher, he asked me which phase are you, Mohan? I said, I stopped, sir, everything. Slowly walking back the road. So what that time happened was like people used to just take it for granted that psychiatric patients, they won't understand anything. I remember I was waiting, my wife was very impatient, we wanted to go for a movie. And the patient was taking a long time, we have to keep on listening. And underneath the table, I just looked at the watch. And after some time, my patient says, "Sir, you are in a hurry." I said, no, you carry on, don't worry. I'm not in a hurry. No, sir, I noticed that you have been looking at the watch. See, they are so very perceptive. I just gave this example of my experience in the 80s. They are so very perceptive. You have to be very careful. Your facial expression, your non-verbal interaction, your body movement, body language. They are very perceptive about everything. So you shouldn't just ignore they are patients and take it for granted. That is the only one thing. And why ethics means we have to value the individual, the patient as an individual. It's not a patient. And remember, ours is a branch which involves several professionals which have totally different orientation. See, for example, psychological orientation, social orientation, anthropological orientation. They would say human orientation, because some people consider psychiatrists are not very human or humane. And they say that because we have resort to inhuman treatment like ECT. But even today, if somebody asks me, I was very fond of asking this question. I don't know whether I asked this question to you, Pastor. What is the sure antidepressant for MD exam? The answer I expect is ECT. None of the antidepressants. Even today, the latest is vortioxetine. Yeah, even that, not a sure antidepressant. The surest antidepressant is ECT. But still, people consider it as a very primitive method, crude method. But they won't consider using electricity by the cardiologist. Well, but psychiatrists use it. Fine, I think that's the way of the world, or way of the professional circle, because they can't tolerate anybody. Perhaps one thing which should be a point of satiation for all of us is that ours is the only branch who could walk to any department. Gynecologists can't go to pediatrics department, pediatrician can't go to medicine department, but psychiatrist is one of the most wanted, not wanted criminal, but wanted professional, medical professional who could walk into any department. Before they used to say radiology, even radiology, no, we use MRI. We can think of even which is not available in Calicut SPECT and things like that. Function, radiological methods, and so on and so forth. So I must congratulate for choosing this topic dilemma, and I must once again express my thanks to all of you, and also I remember this is the second time I'm coming and meeting our erstwhile colleague Dr. Lethi Nair. Thanks to my friend Sushi, Dr. Sushi. Thank you very much. Thank you for your patient hearing. Thanks a lot.